Hello, welcome to Arcana Advances, where we discuss exciting new research in renal pathology performed by our very own physicians. I'm Dr. Rebecca May, and today we have Dr. Z, who will be discussing his recent article in Kidney International Reports titled Anti-Brush Border Antibody Disease, Anti-LRP2 Nephropathy, associated with Lupus Nephritis. Here's the paper, and thank you for joining us, Dr. Z.
Thanks, Rebecca. Thanks for having me.
So first, this is a rare disease. So can you tell us what anti-brush border antibody disease is?
Sure. So it's essentially an extremely rare autoimmune disease targeted against a protein that's present on the apical brush border of the proximal tubules of the kidney. And the protein is called LRP2 Megalin, and it's a massive 520 kilodalton endocytic receptor, whose main function is to basically reuptake at least 30 substances, more than 30 substances actually, in the proximal tubule. And this ranges from vitamin binding proteins to enzymes to ions, all sorts of things. So it's basically an autoimmune disease against this portion of the tubule.
And what patients do you normally see it? What's the patient population affected?
Right. So this is all based on a case series published by our boss, Dr. Larson, and it's a small case series of about a dozen patients, and it appears to mostly affect elderly folks. The range in that manuscript, the age range was 66 to 83, with the mean being 73, so it appears to affect mostly elderly folks.
Okay. And how do they present clinically?
Right. So they present completely non-specifically. It's essentially a progressive form of acute tubular injury. So these folks will present with worsening renal function, which of course is, relatively common in the elderly population. So I think most of them are probably not biopsied, due to polypharmacy, et cetera. So most of these acute tubular injuries in elderly patients are typically ascribed to medications. And then when that doesn't work out, ultimately they end up doing a kidney biopsy.
And what do the findings look like on kidney biopsy?
Yeah, so the light microscopy is entirely nonspecific, once again, similar to the clinical findings. So we essentially have a severe form of acute tubular injury on light microscopy without an interstitial nephritis. So all you're seeing is acute tubular injury on a background of variable degrees of scarring based on other comorbidities that are happening. But really, it's the immunofluorescence is how this is diagnosed. On immunofluorescence, we have three findings, and they're not all the same from patient to patient. So all the patients will have granular TBM deposits for IgG, kappa, and lambda, and that's a big hint. 50% of patients will actually have staining of the apical brush border of the tubules that you can identify by IgG, but that's only half of patients. And then the majority of patients will also have segmental subepithelial staining along the glomerular capillary loops. It looks like it's essentially a segmental membranous glomerulopathy. And then most patients also have Bowman's capsule granular staining.
Do these patients have proteinuria then?
They do. That variable proteinuria that goes along with the acute tubular injury. I think it's presumed to be mostly due to tubular proteinuria and, a probably lesser component of this associated segmental membranous. Okay,
so this in this paper, this is a case report. So can you tell me about how the patient in this study presented?
Right. So this was an extremely unusual case of this disease for a number of reasons. So first of all, the patient presented, it was a 55-year-old man who presented with a range of autoimmune symptoms, in particular pericarditis. And his autoimmune serologies were positive, and he eventually met the diagnostic criteria for systemic lupus. And he had AKI as well as quite significant nephrotic range proteinuria. I think it was about 5 grams, 5.7 grams via UPCR. And AKI, I believe his serum creatinine at presentation was about 1.5.
Okay. And when you got the renal biopsy, what did that look like?
Right. So nobody was really surprised to find active lupus nephritis. So he had full house glomerular immune complex deposition, and histologically there was evidence of glomerular activity in the form of endocapillary hypercellularity and focal crescent formation. So it was overall it was consistent with the class 3 focal lupus nephritis. Okay, but really what was interesting about this biopsy was that this patient had apical brush border staining for IgG kappa and lambda focally within occasional tubules. And of course, there was significant other extraglomerular staining, which you do expect in lupus as a background type of thing, right? So staining along the granular staining along the tubular basement membranes, etc. And of course, the glomeruli were they had quite a bit of immune complex deposition.
So did you stain for LRP2 at that point, or what sort of pushed you over the edge to doing the stain?
Right. So, I would not have suspected this as a disease entity without the presence of the apical brush border staining.
Okay.
So that's really identifying that was critical in this case, which prompted me to order the LRP2 stain. And the way we, of course, utilize the stain is, we'll look for the presence of the anti-LRP2 antibody along the tubular basement membranes, because the normal internal control is the apical brush border staining, which we expect because that's the endogenous, that's the native location of the protein. But when it gets transcytosed to the tubular basement membrane, that's that ectopic presence of that protein along the tubular basement membrane is diagnostic.
Okay. So this was really striking to find in a patient with lupus nephritis. How did he do after the biopsy?
Right. So he was initially treated with a combination of MMF and prednisone, and was discharged and was doing better. However, he returns about 2 weeks later, about 18 days later, with worsening renal function. Now, serum creatinine is about 1.9, suggesting that there's really no good response to, at least, in the kidney function realm, to this treatment. At which point they increased his therapy. They decided to switch from MMF to cyclophosphamide, but they continued the corticosteroids. And then after that, the patient improved dramatically. Renal function returned to baseline. And we also ran serologic studies, direct immunofluorescence, both at the time of biopsy and later, to assess the titer of the anti-LRP2. And we found that it was, at the beginning, it was weakly positive, and then ultimately at the end, about 5 months later, it was completely negative. So the patient it was a complete response once cyclophosphamide was initiated.
Wow. And that's rare for patients with this, right? They don't always respond to treatment?
Right. So from what we know so far, this disease has an incredibly poor outcome, and it's very aggressive. So most people will go to end-stage renal disease within a year following diagnosis of this entity. And there's, a number of treatment attempts have been made. Most of them have been unit therapy with either corticosteroids or rituximab or MMF. However, there was one patient in Dr. Larson's series who did respond, and in that patient they use a combination of prednisone and cyclophosphamide, which is the same combination used in this patient. So it appears that this is at least, to my understanding, the second known case of this disease that responded to therapy, and the therapy really appears to be cyclophosphamide dependent. So
overall, why did you really want to get this case report out there?
Right. So for a number of reasons. So first of all, it's an example that this disease can happen in non-elderly individuals, in folks that are younger. So this gentleman was 55 years old, and typically the mean is 73 years old. So that's the first thing. Second thing is that it's present, as a component of polyautoimmunity. So you have lupus nephritis, and then you also have this disease, anti-brush border antibody disease, hiding in the background of lupus.
Yeah.
And it's really difficult to diagnose, especially because the extraglomerular staining on immunofluorescence lupus is so busy, as we all know. And actually, the presence of extraglomerular staining has a high sensitivity and specificity for lupus itself. But the presence of anti-brush border staining or apical brush border staining is really what tipped me off to the presence. So, this makes me wonder if it's present more commonly in lupus patients. As we know, about 35% of patients that have one autoimmune disease will also have another autoimmune disease. Mm-hmm. And we see tons and tons of lupus. So this, at least to my mind, has, increased my index of suspicion for this disease on the background of lupus. And, I think it reminds us all to look very carefully in the extraglomerular compartments and not just focus on the gloms in autoimmune disease when diagnosing.
So it's very likely underdiagnosed at this point. So raising awareness is a great thing.
Yeah, and I think there's low awareness both between clinicians and pathologists about the presence of the disease. There's only, like I said, only a few case reports. It was originally histologically described back in the mid-'80s and then forgotten about for about 35 years until it reemerged in a case report in 2016. And then this prompted actually quite a bit of work by our boss, Dr. Larson, who went on to, help identify the antigen, this LRP2 Megalin protein. And then that ultimately led to the first small case series of the dozen patients that I talked about. So really, we don't know much about it. It's a relatively new entity, new in quotes. It's been around. It just hasn't been recognized. So, I think that this case report sort of helps remind all of us about the presence of the disease. And actually, I think it helps us explain that it broadens its histologic spectrum and how it may present in younger patients and also on the background of other autoimmune disease.
Well, thank you. It's such important work to get out there. So thanks for coming on and discussing your paper. For more research happenings at Arcana Laboratories and any other information, please visit us online at arcanalabs.com or follow us on Twitter at arcanalabs. And you can also follow me on Twitter at RebeccaMay_RP. So Dr. Z, how can people reach you if they have any questions or anything else they want to discuss with you about this research?
Sure, you can call me at Arcana Labs. Be happy to discuss. Also, you can email me, and my email is on the paper.
Great. Well, thank you so much.